Hello everyone, and welcome to this audio podcast. As part of the Echo Points. This audio podcast as part of a Labstone Motley. This audio podcast as part of a Storm and Scuttle and Turbulence. This audio podcast as part of the Squakish Series and or edition, and this audio podcast as part of a Storm Lobostics production. Through this audio podcast today, a sort of a re-look at renal in around renal and primary care. As a part of this, or some aspects of this audio podcast are in a in a in as part of the Bostics Syndicate series or edition, the in around the Bostics Syndicate series or edition. However, the sort of the sort of crux of primary care in around renal are and have been sort of neglected in amongst to do with to do with an interlink between primary care and secondary care sectors in around sort of the general understandings of renal pathophysiology and where renal pathophysiology is concerned. And so this audio podcast will look and will begin with in around primary care. So it is where primary care is sort of recognized to have an important role or basis in around identifying and managing recipients or CKD recipients in amongst sort of primarily in around CKD stages 1 through 3, in around CKD stages 1 through 3, and then wherein CKD stages are 4 early 4 and 5 are then where primary care teams then look to refer recipients to secondary healthcare services, at least in amongst the adult healthcare population, in amongst pediatrics and young people. Renal disease if and where children or young people are affected, then primarily primary care services tend to have a sort of a very little component in around healthcare services for pediatrics and young people, apart from wherein for example pediatrics and young people, for example, have particular services, particular healthcare services in amongst primary care, sort of in amongst the intermittent sort of durations. So retrospectively, primary care has also been remunerated for maintaining and providing evidence-based care for CKD recipients in amongst stages 1 through 3, but also evidence indicates or informs in some regard in between CKD stages 3 and 5. There is evidence that a portion of CKD recipients who are undiagnosed, and the management can be suboptimal. There is evidence that not all practitioners or family physicians, for example, accept sort of national guidelines. At the same time, primary care. In amongst primary care, a range of concerns have been have been sort of heightened by general practitioners or family physicians, including difficulties associated with, for example, assigning a diagnosis or diagnoses, the stigmatizing effect of a diagnosis or diagnoses, explaining the concept of CKD to recipients or patients, achieving arterial blood pressure or ABP targets, complicated polypharmacy polypharmacy or pharmacotherapeutics or regimens, and in amongst a referral to secondary care or secondary healthcare services, again, where primarily in amongst the adult healthcare population. Introduction to in around some introduction to guidelines. So there have been guidelines in around guidelines in around CKD, but at the same time there have been a sort of wherein the evidence has informed that that in amongst a CKD as a condition, it requires primary care physicians or family physicians to have a sense of a change in behavior in as regard to in regard to sort of the approach of in around the approach of CKD and CKD symptomologies. Changing sort of the professional behavior or behavior is recognized or should be recognized as wherein and a point of addressing the implementation, a sort of an implementation gap or a gap where the understanding around the understanding of CKD is around the understanding of CKD sort of more generically. And then now looking at in as part of this audio podcast in around how is CKD chronic kidney disease classified. So CKD is divided into 5 stages based on estimated glomerular filtration rate or glomerular filtration rate, EGFR or GFR, according to guidelines such as the KDO OQI classification evidence, and a minimum of 2 EGFR values, at least 3 months, in around at least 3 months should be used to diagnose and classify CKD. Temporary rises in creatinine, for example, tend to be common, and a diagnosis of progressive CKD should only be based on a sustained decline in renal insufficiency. Additionally, people with EGFR of 60 mil per min per 1.73 meter squared or over should not be considered to have CKD unless there is other evidence of renal insufficiency or renal pathophysiology detriment. In CKD stages 1 and 2, other markers of renal insufficiency are required for CKD diagnosis, since wherein in CKD stages 1 and 2, even in sophisticated laboratory environs, where for example excuse me, wherein for example when for example specialists in specialist labs specialist lab laboratory professionals in around CKD stages 1 and 2, there is sort of a wherein at population level in amongst sort of the staging of CKD 1 and 2, It is where laboratory specialists and laboratory professionals, for example, would say would inform clinicians at primary care and in amongst secondary care, for example, the GFR or EGFR is for example not significant enough to actually warrant a formal CKD diagnosis. There may be a diagnosis in around CKD stages 1 and 2 in around the symptomologies of AKI or acute kidney injury, since CKD stages 1 and 2 generally are CKD stages that do not implicate or are not implicated to cause a sort of whole pathophysiological sort of detriment to and in around renal pathophysiology or renal physiology. Most markers of disease can be, most markers of the conditions can be identified through radiological investigations. Additionally, so for example, in around conditions such as polycystic kidneys or abnormal urinalysis findings, for example, in certain conditions such as microscopic hematuria, where there can be small traces, but where the traces are enough to cause sort of urinary tract anomalies. So conditions such as hemolytic uremic syndrome, for example, that is identifiable more in pediatrics and young people than in the adult population. Then there is in around a little bit around identification and around estimated glomerular filtration rate. So it is the most, or has been the most, sort of broadly utilized sort of calculation, if you like, to determine serum creatinine concentration or creatinine concentration, and it's calculated from the amount of creatinine, for example, creatinine being a biomarker in a 24-hour, where creatinine being a biomarker, sort of a biomarker used to assess to assess and help determine renal insufficiency through muscle breakdown. And it is where EGFR can be calculated from the amount of creatinine, for example, in a 24-hour urine collection. Although in more recent publications and more recent literature, 24-hour urine collections are not normally sort of not so routine as they as now. There are more sort of sophisticated laboratory analysis and investigations that can help determine creatinine or serum creatinine, and so a single collection of in around through voided urine and sort of a blood specimen can help to determine GFR or EGFR. Creatinine clearance also tends to overestimate or can overestimate sort of glomerular filtration rate, because creatinine is secreted by tubules and filtered by the glomerulus. And measurement in around the sort of measurement of creatinine clearance, it also involves timed collections, in amongst a urine, in amongst voided urine, in as part of sort of primary care practices and secondary care practices. So a little bit a look at sort of the KDIGO guidelines. So again, KDIGO had defined CKD as renal insufficiency or glomerular filtration rate of where it's less than 60 mil less than 60 mil per min per 1.73 meters squared for at least 3 months, 3 months duration or more. Renal insufficiency can also be ascertained by the presence of high titers of albumin, which can be detected by urinalysis and confirmed through ACR or albumin creatinine ratio in amongst your and amongst and through urinalysis or voided urine specimens. At the same time, renal conditions in around the severity have been classified into again 5 stages at level of in around where the level where the 5 stages are interlinked with the in around the severity of GFR and the presence of abnormalities and around the abnormalities where renal pathophysiology is concerned, aligned to different forms again of CKD. Classification is a predictor or can be a predictor of and around the complications and around the in around renal pathophysiology where it is affected and where it can where the progression in around renal pathophysiology is affected, and also offers a guide to the need or requirement for further investigations and follow up and in where there is a requirement for nephrological specialty referral. So that draws this audio podcast to a close. This audio podcast as part of the Equipoise. This audio podcast as part of a Lab Storm Motley. This audio podcast is brought as part of a Storm and Scuttle and Turbulence. This audio podcast is part of the Squakish Series or edition, and this audio podcast as part of a Storm Lobostics production.